All right, let's jump right into this explainer. If you've spent any time in the pediatric ED, you know the exact pressure cooker I'm talking about. We're talking about an environment where a single, slightly ambiguous symptom can point you down two completely different clinical pathways. It is the ultimate test of your diagnostic reasoning, usually with a ticking clock and absolutely zero margin for error. So imagine you've got a kid presenting with abdominal pain and microcytic anemia. Your brain might immediately jump to ordering a defroxamine challenge, right? But hold on a second. We have to ruthlessly audit that exposure timeline first. Are we actually looking at a slow, creeping environmental accumulation or a sudden, massive pharmaceutical overdose? Today, we are going to build the mental frameworks you need to confidently separate the true clinical signal from all that distracting noise. Here is our roadmap for today. We'll start by tackling heavy metals, looking at lead versus iron. Then we'll dive into corrosives, comparing acid and alkali ingestions. After that, we'll break down the chronological divide in neonatal sepsis, and finally wrap things up with a crucial toxicology pearl on acetaminophen versus salicylates. Okay, part 1, heavy metals, lead versus iron. The absolute crux of this 50-50 dilemma, it's all about the timeline. Look, lead poisoning doesn't happen overnight. It is a slow, chronic environmental insult. We're talking months of exposure to old, peeling paint or lead pipes, slowly dragging down a child's neurodevelopment. Iron toxicity, on the other hand, that's an acute, sudden nightmare. Usually, it's a toddler getting into a bottle of mom's prenatal vitamins because, let's be honest, they look exactly like candy. Now, this is where it gets really interesting. Check out those little blue dots inside the red blood cells. That is basophilic stippling, and honestly, it is your ultimate diagnostic signal for lead poisoning. You'll hear people talk about a lead line on the gums, but in pediatrics, that's mostly just clinical noise. It's incredibly rare. Stick to the basophilic stippling for lead. For iron, your true signal is going to be spotting those radio-opaque pills sitting right there on a plain abdominal x-ray. If you are dealing with acute iron toxicity, you're going to see it march through 5 brutal, incredibly rapid stages. It kicks off violently with hemorrhagic gastroenteritis. Then you hit this terrifyingly deceptive phase of latent stability, where the kid actually looks like they're getting a bit better. Don't fall for it, because underneath they are actively crashing into metabolic acidosis, which spirals into hepatic failure, and if they survive all that, they are looking at delayed gastric outlet obstruction just from the sheer internal scarring. So how does this actually dictate our execution? Well, whatever you do, please do not make the classic dumb mistake of jumping to chelation for lead way too early, like at a level of 10. For levels between 5 and 44, you investigate the environment and optimize their iron and calcium, period. You only pull the trigger on oral succimer when levels hit 45 or higher. As for iron, you initiate that IV defroxamine challenge if levels blow past 500 or if your patient is symptomatic and acidotic. All right, moving on to part 2, corrosives, acid versus alkali. The massive diagnostic dividing line here is the exact type of tissue destruction, which is dictated entirely by pH. Acids, think toilet bowl cleaners, cause coagulative necrosis. They essentially cook the tissue. This creates a really tough eschar, basically a giant scab, that actually limits deeper penetration into the esophageal wall, though it can still pool and wreck the stomach. Alkalis, like drain cleaners, are a whole different beast. They cause liquefactive necrosis. They literally saponify fats and melt proteins, penetrating incredibly deep and carrying a massive, massive risk of immediate esophageal perforation. So if you've got a stable patient who somehow ingested an alkali drain cleaner, maybe they're drooling but they're alert and protecting their airway, the protocol is actually very rigid. You need an upper endoscopy. But here's the kicker. There is a strict 12 to 24-hour window for this. Scope too early, you'll underestimate the damage. Wait past 24 hours, the tissue becomes so friable that the scope itself might literally cause the perforation. And here is a major, life-threatening trap you absolutely need to avoid. Never, ever attempt to neutralize the chemical. Human instinct screams at you to give the milk or water, but neutralization is an exothermic reaction. You will literally create a secondary thermal burn right on top of the chemical injury. Also, absolutely no MSS. Forcing them to vomit just drags that corrosive agent right back up, doubling the damage. Keep them in PO, stabilize that airway, and prep for the scope. Section 3, neonatal sepsis and the chronological divide. When a neonate crashes, your absolute tipping point is the 72-hour mark of life. That single number tells you exactly where the bacterial fingerprint came from. Less than 72 hours? That's early onset, meaning vertical transmission from the maternal birth canal. You are actively hunting Group B strep, E. coli, and Listeria. Past 72 hours, we shift to late onset. That's environmental or healthcare acquisition, so your primary actors instantly become coagulase-negative staph, Staph aureus, and Klebsiella. Because of this specific microbial shift, your pharmacological execution has to be flawless. Yes, standard broad-spectrum coverage uses gentamicin to hit that gram-negative E. coli. But gentamicin has a massive blind spot. In that early onset window, you absolutely cannot withhold ampicillin. Without it, you have zero coverage for Group B strep, and critically, Listeria. You'd be leaving the infant's central nervous system completely wide open to attack. And finally, Section 4, our toxicology pearl on acetaminophen versus salicylates. These might be two of the most ubiquitous over-the-counter drugs on the planet, but from a toxicological standpoint, they couldn't be more different. Acetaminophen toxicity is entirely a story of glutathione depletion in the liver. How do we fix it? We replenish it with N-acetylcysteine, strictly guided by the Rumac-Matthew nomogram starting at the 4-hour mark. Salicylates, like aspirin, totally different ballgame. They trigger a wildly complex dual acid-base derangement. Just look at how the arterial blood gas tells the story here, a pH of 7.43, so leaning slightly alkalemic, driven by a wildly low PCO2 of 22. That is your primary respiratory alkalosis, happening because salicylates are directly whipping the brain's respiratory center into a total frenzy. But simultaneously, underneath it all, the toxin is decoupling the electron transport chain, causing a massive pileup of unmeasured acids. Boom, a high anion gap metabolic acidosis. It's a literal physiological tug of war. Because of this chaotic cascade, your definitive move isn't some magic antidote, it's urinary alkalinization. By pushing sodium bicarbonate, you crank up the urine pH and ionize the salicylate. This essentially traps the toxin right inside the renal tubules so it gets flushed out, completely preventing it from crossing the blood-brain barrier. And remember your hard stops. If that level cracks 100 milligrams per deciliter, or the patient's mental status starts slipping, you bypass everything and go straight to hemodialysis. So as we wrap up today's explainer, I want to leave you with this thought. In the sheer chaos of a pediatric emergency, the line between a brilliant save and an absolute tragedy often balances on a single, subtle timeline or a rigid threshold. When you step into your next 50-50 diagnostic dilemma, are you going to let the clinical noise distract you, or are you ready to confidently execute on the true signal? Keep questioning the data, trust your frameworks, and I'll see you in the next explainer.